so many women come in and they're like, well, I'm not ovulating. My progesterone was low. I'm like, what day did they pull it? Day 21. How long are your cycles usually? 60 days, 90 days. I'm like, okay, well, of course you didn't show you were ovulating. They tested you at the wrong point in your cycle. And this is where individualized medicine is like key. This is key.
Hey everyone, I hope you enjoyed this episode brought to you by Let's Get Checked. You can save 20% off your purchase by visiting tiyLGC.com/PCOS and using the code PCOS20 at checkout. This episode is also brought to you by Polly, the go-to marketplace for women looking to find a virtual hormone health specialist. Right now you can save $10 on your first Polly appointment using the code PCOS Oracle. That's PCOS Oracle, ORACLE. Visit polly.co or visit @polly.co on Instagram today and find the right specialist for you. Now I hope you enjoy the episode. Hello and welcome to episode 64 of the PCOS Oracle podcast. And in today's episode, I speak with Caitlin Johnson. Caitlin is a registered dietitian who loves great food and people even more. She started her own family naturally in spite of a PCOS diagnosis. Now she uses her experience, evidence-based nutrition, and expertise to guide other women with PCOS into healing and fertility. You can find her on Instagram @PCOS Fertility Nutrition. Hello and welcome to the PCOS Oracle podcast, Caitlin. It's such an honor to have you on the podcast. I've been following your Instagram page for quite some time now, and I really enjoy the content that you share. Super valuable and informative. And you're just an inspiration to a lot of women, great motivation. And yes, I'm really excited and honored that you agreed to come on to talk about this specific topic, which is ovulation, which is very, anovulatory cycles is a very common kind of symptom of PCOS. So I'm excited to kind of delve into this topic and to help our listeners kickstart their ovulation, start producing progesterone, which is super important. And just to provide our listeners with some knowledge and some step-by-step information so they can kind of finish this into the episode and just get started, hopefully improve their symptoms, their PCOS balance, their hormones and all that. Before we delve into all that important stuff and the good stuff, can you talk about your own PCOS story and your journey and just tell our listeners a bit about yourself?
Yeah, absolutely. Well, thank you, Despina, for having me. I'm very happy always to go on podcasts and just give good free information to women with PCOS. I know that when I was diagnosed, which I'll explain a little bit in a second, I felt like it was a little bit of a sea of unknown and desperation. I just got dropped off of a boat and I was in the middle of the ocean and I didn't know which way to go and wasn't offered a whole lot of help from the medical practitioner that diagnosed me. And so it was kind of like, okay, well, sink or swim. What am I going to do? I really had to fight for myself. So I am a registered dietitian. I work with women with PCOS, specifically fertility. And part of why that became my specialty was, sitting in a medical office in a summer after I gained 60 pounds while training to run a half marathon and eating okay. I mean, I'm sure I wasn't eating perfectly. I still enjoyed ice cream and biscuits, but I wasn't eating terribly either. Nothing to constitute, 60 pounds in 3 months while working so hard. I had just come off the birth control pill and was trying to see if I could handle my acne on my own, which is why I was originally put on the pill. And just all these symptoms came up, the weight gain. And I went to the doctor and, they did some labs. They suspected PCOS. So they ordered an ultrasound. They saw the string of pearls, very common in PCOS, and diagnosed me with PCOS. And I said, well, what's PCOS? And the doctor said, well, it's the number one reason in America why women can't get pregnant. And it was like a shot to my gut. First of all, I was 19. I wasn't dating anyone seriously. It wasn't like I wanted to be a mom the next day, but I wanted to be a mom like that. Ahead of a career or any other thing, that was a pursuit of mine that was important. And I felt like in that moment, it was robbed from me. And so I thought well, why would it be why I can't have kids? Is this cancer? Polycystic sounded like cancer. I mean, it was just a very scary moment. And I said, well, like, so what do you do about it? How do I treat this? And he said, well, we're just going to put you back on birth control and I'll give you a prescription for metformin. And I said, well, what's metformin? He said, well, it's just a drug that we give people to lose weight and treat diabetes. And I was like, whoa, whoa, whoa. Do I have diabetes? And he's like, no, you don't have diabetes. It's just, we use it for this because it helps people lose weight. And, the room was spinning. Here he is in this white coat, just delivering with terrible bedside manner, very honestly, in a sense, I don't want to say inaccurate information, but such a poor rendering of information, not helpful and not inspiring of change. And so I left and thought, like, okay, well, this can't not be the answer. I did go back on birth control. I did not go on metformin at that moment because I thought that there's just something wrong with this. And I just started this trajectory of figuring out, how do I manage PCOS? And it took me years. It took me a lot of work and years to get a hold of good information and just layer in change one thing at a time, which is something I really work with my patients and clients on. Is, we don't change everything about you overnight. It took you years to get here. It may take months to reverse some of this. You got to be in this for the long haul. And some misguided approaches. I saw a nutritionist who put me on a raw food diet. It was really carb heavy, and while it did pull out some junk in my diet, like, it did not help me manage my insulin resistance at all. So I went to school, studied biology and nutrition, became a dietitian. And through my time in school, I'd been seeing a naturopath who'd really helped me kind of zero in on a way more natural approach to treating my PCOS, really at the root cause, and did a lot more functional medicine testing. And so it kind of started me on this journey of, like, okay, I can handle this. I went off birth control for like the third time in my life. I still had an irregular cycle, even though I was managing so much very well. And I went and did my internship, fell in love, got married. And then it was like, okay, we're going to have babies, right? Like, I have my PCOS pretty well managed. And it didn't happen overnight for me. In fact, it took us a few years. And you tend to have to wait like a year before anybody's willing to listen to you and help you, even with a PCOS diagnosis. So I went to a series of very, again, disheartening interactions and appointments with an OBGYN, couple OBGYNs who just didn't get it. I don't think they really understood PCOS well enough to help me. I would walk in and say, okay, I've been tracking my cycles. I have 75 to 90-day cycles sometimes. Sometimes I have a 45-day cycle. Am I ovulating? And the doctor would be like, that's a great question. Let's try and get the answer to that question. And I was like, okay, well, how do I do that? And she'd be like, okay, well, go buy ovulation kits and pee on them. And at that point, like, I knew, there were some of the technologies that are around right now were not around then. And so I knew that I was getting positive after positive after positive ovulation tests. And like, I'm not fertile Myrtle. I'm not a mom yet. So something's wrong here. My LH was so high compared to my FSH, and I just wasn't ovulating early in my cycle, although I was ovulating my cycle, and I was able to kind of zero in on that. But it led me to all the research. At this point, I had already started a private practice, and I was just like, okay, well, this is it for me. I'm going to figure out how to get pregnant, and then I'm going to help every woman that I can with PCOS get pregnant too. And yeah, so that's kind of my story. It took us, after I spent like probably 6 months, literally my room looked like I was writing a PhD dissertation. Like, I just had like literature reviews, books, everything's highlighted and thumb tagged, like, what can I find out about this diet? What can I find out about this supplement? What about acupuncture? What about yoga? Like, what does the research say will help me? And how do I avoid something like IUI or IVF? Can I do this naturally? I really believed in my body's ability to do it. And for me, my mom really struggled with infertility. So there was a part of me that thought, like, well, maybe this is just like my family's how we are. Like, she did successfully conceive, obviously, but it was hard for her. And we figured it out. Like I started developing a method. I started using it with patients in town. I went and knocked on the door of every OB I could and said, send me your PCOS patients. So they started coming. Then after a while, they really started coming because the doctors were like, I don't know what she's doing, but it's working. Just go see Caitlin. And by the time we had our first baby, when she was like 1, I was like, okay, well, it might take us a little while. My cycle's not yet regular after this baby. I was still breastfeeding. But like, let's just start trying. We wanted them maybe like 2 years apart. And I swear, like one shot and we were pregnant again, which I know some of your listeners are gonna be like, I hate you. But it just spoke to me that what I had done at the root cause level to heal. And as I started re-implementing those things after my first baby, it helped support a healthy ovulation and quality follicles developing to the point that when we were ready again, we conceived and had another full-term live birth, healthy baby. So that's kind of my story. Maybe you can tell I'm just so passionate about this. There's not enough good information out there, and people get told that they have PCOS and they think that they're infertile. And that's not true. PCOS is not an infertility diagnosis. It's really a subfertility diagnosis. It takes women longer to get pregnant. That's what that subfertility means. It doesn't mean that they can't get pregnant most of the time. It's just that it takes longer. And there's a reason for that. But I could ramble on and on. So I want to let you ask me questions that you would be relevant to your listeners and your audience.
No, I love your story and how you're super open about it and you're doing what you're doing. I think it's really inspirational and it's incredible. And I feel a lot of our listeners can relate to your story and your journey, because I feel it's obviously when we go to the doctor, they give you that standardized advice and you're just feeling super depressed after that. You know, you've got PCOS and you're just like, what? You're just like all these questions like, what is this? Did I do this to myself? Can I never have kids? And all these kind of questions come in your mind. You kind of blame yourself and you just kind of get stuck in this negative mindset. And then eventually you start to do that research because you realize there is a way out. There's a way to, overcome PCOS naturally and balance your hormones. And you start to do the research, spending hours on end, just researching studies and just kind of doing trial and error, trying to change things in your life to hopefully address your root cause. But yeah, it's amazing what you're doing. And ovulation, like you said, it is really important. It's key when you're looking to conceive. So focusing in on that is very important. And like what you mentioned when your OBGYN suggested, peeing on an ovulation stick obviously doesn't. When women have higher LH, it's always going to come positive. It's not going to be negative because that LH signals that
just the baseline is higher.
Exactly.
Yeah.
So it's obviously it's not going to help. So it's just like a waste of kind of money. But ovulation is really important. So what other reasons do women with PCOS need to focus on? Or in general, just why is ovulation so important? Like why should we be focused on it for our health, apart from fertility reasons?
Conception. Yeah, absolutely. So, we think about female hormones. We often think about progesterone and estrogen. Estrogen's really the builder of a lot of things in your body, but particularly during your menstrual cycle, it helps build kind of the bulk in your uterine lining. And then after you ovulate, progesterone kind of comes to the scene. You don't really have any appreciable amount of progesterone in your body until you ovulate. And progesterone really helps to kind of stabilize the uterine lining, make it kind of safer in a sense, is kind of a good layman's way of saying it. Helps it from over bulking up. So a lot of times women come see me and they'll say, I don't bleed for 2 or 3 months, and then I'll start having a period and I'll bleed for a month on end. Now that could be for other reasons like polyps or fibroids, but that sometimes is just because you've been making so much estrogen and there's been no progesterone around to say like, hey, let's slow down this building of the uterine lining and safe. And so without ovulation and without progesterone, we have a scenario where you can build up so much of your uterine lining and then have horrendously long bleeds, very essentially increased risk for different types of female cancers. Progesterone helps to regulate your immune function. Progesterone supports a healthy thyroid. So, outside the consent, if you're not really progesterone, functions in your body like that, readers of it, right? Do you want regular periods? Do you want healthy breasts? And you're not getting really bad kind of pain, tenderness right before your period. Progesterone is key to a lot of that. If you want to increase your feelings of kind of well-being later in your cycle, healthy amounts of progesterone helps with that. It can help lower your risk for breast cancer, because what it does is when you ovulate and your progesterone levels come up, it opposes estrogen. And so your estrogen levels come down. And there are certain variations of estrogen that if they kind of are left unchecked and they're too high for too long, they have more of a linkage, according to the research, in developing breast cancer. So ovulation is actually really important. And I think body literacy and the idea of us being taught at a young enough age when we start getting our periods and we start having a cycle about our periods. I don't know what it's like in the UK or other places around the world, but nobody talks about ovulation. They just talk about don't get pregnant when you don't want to, and like be prepared for your period. Well, so we all just think like your period. Sometimes I'll ask people like, tell me about your cycle. And all they do is tell me about their period. They don't understand that their cycle is from day one of their period to the last day of the next one. Yeah. Yeah. So just even that, and that's not a woman's fault. They just were never given that information. And so to understand why ovulation is so important, just really, it's like, we've given people a car, but we haven't really given them the keys or driving lessons on how to use it. And so many of us from so young exhibit symptoms of really painful acne, irregular periods, and then very long bleeds because you've built up a huge uterine lining. And so just the rote answer from so many practitioners, whether it's an OB or just your family medicine doctor, is oftentimes putting a young woman on a birth control pill to just kind of mask those symptoms. And that's what happened to me. We didn't know at 16 when I went on birth control that I had PCOS. We probably could have figured it out earlier had we done a little bit more digging. But the solution to acne is put some medicine on it or give it some birth control. It's never, why is the acne happening, right?
Yeah, it's never looking at the root cause. We just always fixate on a symptom. And that's what doctors tend to do. It's like, look at the symptom. Mm-hmm. They look at the period. You got no period. Okay, here's the birth control. You got acne. Okay, here's the birth control pill. Oh, you got this birth control pill. So like,
right. And I should say, I'm not against somebody being on the birth control pill if they need to, or that's their choice, for many reasons, but I am pro-informed consent. Mm-hmm. And if a doctor is not telling someone what the birth control pill is doing to them, what risks it may increase, like, hey, PCOS, huge root cause of it is insulin resistance. Did you know that birth control, it may help you with these symptoms, but it's going to increase your insulin resistance? Whoa. Somebody might go, okay, I'd rather take 3 or 6 months and try working on this in a different capacity than just slapping a pill in my body every single day, Yeah,
because I just feel like the birth control pill as well, it's something that prevents pregnancy and shuts down like the whole ovulation process. So sometimes you think, why are women with PCOS who aren't ovulating anyway taking it? If that kind of makes it just like, well, it doesn't make any sense.
Yeah, I remember being told, it's going to trick your body into thinking it's pregnant. And I was like, when I started looking at the research, I was like, hey, no, this is tricking your body into thinking you're in menopause.
Yeah.
Not pregnancy. This is way closer to menopause than pregnancy. I've been pregnant and I felt effing great. I did not feel that way on birth control.
Yeah.
So, so yes, those are some of the reasons why women should be concerned about ovulating. And from a conception standpoint, like, let's just talk about a scenario. Let's say Patty walked into my office, and she's a beautiful woman, very kind-hearted, very engaged in her church community, very hardworking, just an incredible woman. First of all, you'll notice there are things about her that I notice beyond just her PCOS, because PCOS is just one little sliver of something that's affecting her life. But she and her husband have been trying for a while, and they want to have a baby. Okay. So she's coming to me because her doctor just told her that she has PCOS. She didn't know it because she'd been on birth control since she was maybe 18 years old. And now she's 27. She comes in, she just got her PCOS diagnosis. She's 250 pounds. She's 5'6". So you could give me that in kilos or stones, to translate it for the listeners. But she's got obviously a little bit of extra weight. And the doctor just said, go lose 10% of your body weight. Maybe you'll regulate your cycle. Didn't even give her a chance for her cycle to regulate coming off of birth control. Just basically told her, like, okay, well, you've been off the pill for 6 months, lose 25 pounds. Okay, that's a lot of weight for somebody to lose. And so she's like, how do I do it? Well, maybe go see a nutritionist, maybe go on the keto diet. I mean, this is what I'm hearing from people, right? So she comes in and she's like, okay, I'm supposed to lose 25 pounds. He thinks I should maybe go on the keto diet. What do you think I should do? And I'm like, okay, well, let's gather some information. Do you know if you're ovulating? That's oftentimes one of the first things I try to get an answer on, because sometimes Patty's ovulating 4 times a year, and that's better than not ovulating at all. Does she know that she's ovulating then? Does she have the tools to know when to time sex to improve her chances of conception? Oftentimes, no. I have no idea when I'm ovulating. I've been peeing on these sticks all the time. Don't know anything about, like, checking your basal body temperature or your core body temperature, don't know anything about cervical mucus, like, have not been given any of tools to listen to her own body's way of communicating ovulation. So we zero in on that. Well, in this scenario, let's say Patty has a cycle every 90-ish days, sometimes 85 days, sometimes 100 days, but she's bleeding every 3-ish months. And we can find out she's ovulating. Well, she had 4 chances, if she ovulated all of those cycles, 4 chances in a 12-month period to get pregnant. She had like 20 days maybe to optimize sex timing, maybe, to get pregnant. Your bestie who has a cycle every month and is ovulating every month had 12 chances, maybe even 13 if she has like a 25-day cycle. And so telling a woman who has PCOS that may or may not be ovulating and has very long cycles, go try for a year and then come back, is a very frustrating scenario, because first of all, they may not have even known enough to ask, am I ovulating, or that they're only ovulating 3 or 4 times a year. But to then it's basically like throwing her out in the ocean and saying, swim back to shore. It's such an impressive feat for somebody to be able to conceive when they're only ovulating 4 times a year. So one of my goals is to zero in, are you ovulating? When are you ovulating? And then we do everything we can, if they're not ovulating, to get them ovulating. If they are ovulating, how do we get that cycle that's 85, sometimes 100 days long? How do we get that down to 40 days long? 35 days long, maybe 30 days long, even 60 days long would be a great increase, right? Then she'd have maybe 6 chances in a year to get pregnant. And as soon as Patty PCOS learns that how her body communicates ovulation to her, she may time sex perfectly in the first 3 months and get pregnant. It also might take a year because it just takes some time to deal with these root cause things. But I think helping people kind of reframe the conversation, not about lose weight, which is just a symptom, to, am I ovulating? How do I increase the frequency of my ovulating? Sometimes we find out there's other reasons that are going on around ovulation that are not helping them in their fertility pursuits. But changing the conversation and taking the shame and the stigma away from like, hey, just go lose weight and it might all work out for you, is also just like, I think, an emotional release for a lot of these women, and helps them realize like, hey, this isn't like my fault. You know, and so many women, I'm sure you understand this too with ladies you coach and what you hear from your followers and listeners, they've tried every diet. Like, shame on this doctor to just say, go lose 25 pounds without giving them real resources and how to do it. And I don't expect OBs to know how to help somebody necessarily lose weight, but at least give them a referral to somebody who could.
Mm.
You know?
I mean, yeah, I've even had followers of mine say, I've had my endocrinologist has told me to follow a 1,300 calorie diet. It's like, why has this person that doesn't know anything about like weight loss and this kind of stuff to suggest that a patient of theirs follows a super low calorie diet? Like,
and for anyone that has been given that information, turn everything else off. If you're cooking, stop for a second and listen to this. Who should eat a 1,200 or 1,300 calorie diet? A 2-year-old. This is not what a woman who's going to try and bear a child should be eating, even if you need to lose weight, because you need optimal nourishment to be able to create an egg that's quality enough that's going to be able to get fertilized. You need nourishment stores for if your first 3 months of pregnancy are horrific and you can't hold any food down, your body's going to rely on the things you ate for the last year. So it is very important that you do not follow that. The other reason why you should not follow a 12 to 1,300 calorie diet is we as human beings are designed or have evolved to adapt. And if you start eating very low calories, your metabolism will think food is scarce, it is wartime or famine, and it will adjust down the way that it utilizes calories to burn less and conserve. And what that's going to do to you 3 months from now or 6 months from now or 6 years from now is really make it hard for you to rev your metabolism back up. So you lose this kind of like metabolic burning advantage when you do very low calorie diet protocols, because you're basically telling your body, turn the fire down. And that may work for a week or 2 weeks or 3 months, but it's not going to work for you long term. And it's not the best way to set you up for conception, not by a long shot.
Seriously, no, it's not. And it's just, yeah, like, it's not sustainable either. These food calories is energy. And if we're not giving our body the energy to function, we're gonna start to experience side effects. Our hormones are gonna go out of whack. And like what we kind of don't realize is that when we're not eating enough food, the kind of first things that go is our menstrual cycle, because we're not eating enough. So it's like, if you're not eating enough for yourself, then how are you supposed to feed that growing human being? So
Amen.
That kind of thing just like gets cut off, and all these other kind of nutrients just get shifted somewhere else. You don't need beautiful hair, so all those, your hair you start to lose hair and all this kind of stuff. So that people don't realize that your body needs energy. This is just energy, and focusing on the whole weight loss is just not getting to that root cause, and you're just causing a whole bunch of other issues that are just not helping you get from where you are now to balancing your hormones. You're just causing extra stress on the body.
And I should say, like, the reason why doctors are recommending that is they have seen that with some amount of weight loss for some women with PCOS, it does help with the frequency of their cycles, and it has helped IVF, live birth rates, or just even success in getting pregnant, maybe not sustaining the pregnancy. It has helped spontaneous ovulation and spontaneous pregnancy, so getting pregnant without that any medications or advanced reproductive technologies. However, like as Despina just said, and weight is really a symptom of another issue. And so as you start addressing something like insulin resistance or high levels of cortisol, which signal to your body to store weight in your abdominal region, as you correct those underlying things that also improve ovulation, it will assist in losing weight. But the goal isn't necessarily just lose weight. It's addressing those underlying hormonal imbalances that then will translate to symptom improvement. And across the board, that may be acne, may be hair growth, may be your hirsutism, it may be ovulation, which is so important for conception. So it's so important. And what you said is so right. Like, again, our bodies are made to adapt to the situation that we are put in. If you don't have enough energy, or sometimes you're eating good amounts of energy, but it's very nutrient poor, then your body will think this is not a safe scenario to get pregnant, and it will downshift your fertility. And honestly, like, a lot of women come to me and they feel like their bodies are betraying them, or they've been abandoned, or, they feel such shame. And it's like, hey, 200, 300 years ago, you're the one that would have made it. Like, your body is trying to adapt to the situation it's given. It knows how to store extra fat. It knows how to downregulate your cycle when it's not safe to have a baby. Just given our modern food environment, given our lifestyles in this century where we're very sedentary for most of our jobs, the chemical exposure that we have, so many different things that kind of play into our hormonal balance, do affect fertility factors. And it's important sometimes to take a step back and go, okay, well, maybe this is my body saying it's not safe. What do I need to do to help it feel safe so I can get pregnant?
Yes, 100%, 100%. So if, as a woman with PCOS, for our listeners, if they're not ovulating, we'll kind of get to the facts about how to find out if you're ovulating, like what are these kind of signs. But if they want to get tested, what tests can they do to establish that there's an issue going on with ovulation, they're not producing progesterone? What do they need to ask for?
Yeah, so I would say that most women have available to them a practitioner that can order labs, and it's typically blood work that they're ordering, right? So you go into your doctor and you say, hey, I have PCOS. Whether you're trying to conceive or not, I want to make sure that I'm ovulating naturally. Can we do some tests to pinpoint this? So oftentimes what a doctor will test, it's kind of a basic metabolic panel. That's fine. They might look at fasting blood glucose. They'll probably look at your lipids and cholesterol. That's not so much to help you with your ovulation, but just your general health. They might, if they suspect PCOS or you told them you had PCOS, they might look at your A1C. We can talk about how that's not the most helpful parameter to look at insulin resistance. I always ask for, at the very least, a fasting blood glucose and a fasting insulin number, and that can help us do a simple calculation called the HOMA-IR, and that helps us determine what your level of insulin resistance is. I prefer to ask for an insulin assay, which is basically where you go into the lab, you drink a certain amount of like a glucose drink. It's kind of like soda. And then they draw your blood at certain time points, usually 30, 60, 90 minutes and 2 hours. And they look at your blood sugar rise and your blood sugar decreasing. With the insulin assay, they also pull insulin at those time points. Because what I see a lot in practice is women have a normal A1C, they have a normal fasting blood glucose, but the amount of insulin it takes them to get that normal figure is astronomical. And so their body's producing a whole lot of insulin to get those numbers to what their doctor's looking at saying normal. So a lot of times I'll get lab work and I'll send them back and say, go get an insulin assay. The doctor will fight us a little bit, and then maybe they finally do it, or we just order it on our own. And then the doctor's like, wow, your insulin levels are really high. And it's like light bulb goes off. So that's definitely something to be asking for. But in terms of kind of the female hormones, they'll usually check estradiol, they'll check LH, which is luteinizing hormone, they'll check FSH, your follicle stimulating hormone, they'll check progesterone levels, they'll often check prolactin, which is that kind of breastfeeding hormone. It's often very high in some women with PCOS. which can be related to PCOS, or it can be related to like a tumor in your pituitary. So if it's high, that's definitely something to be following and get checked out. And that high level of prolactin alone, that one parameter can shut down ovulation. Think about women that you've heard, in your lifetime, like, well, they were breastfeeding and so it was harder for them to get pregnant, or people use breastfeeding as birth control, which they shouldn't, but it does, can impact your cycle. And that high level of prolactin is one of the ways that it can. So looking at those. Now, the interesting thing about looking at a lot of these female hormones, the estradiol, the LH, the FSH, the progesterone, they're at higher or lower levels at different points in your cycle. So a lot of times we want to look at LH and FSH early in your cycle because they give us a little bit of an idea of what your body's trying to do as it's endeavoring to ovulate. Whereas we want to look at progesterone after we suspect you may have ovulated. What I see most practitioners do is just order a 21-day progesterone. So what that means, a 21-day progesterone is day one of your cycle is the first day of the bleed where you had to do something about it. If you spotted for a day, like you wiped with toilet paper and you just saw a little bit of brown spot or a little bit of like blood tinged urine almost, that's not really day one. Day one's like I had to use a tampon or a menstrual cup or a pad. And I had like some level of appreciable flow. That's day one of your cycle. So 21 days later, your doctor is going to check progesterone levels because they're assuming you ovulate around day 14. And so they're looking for a certain level of progesterone after you would have ovulated, and this corpus luteum, what gets left behind in your ovary, starts producing that progesterone. And for so many women with PCOS, this test is kind of like, okay, well, I had no progesterone. And it's like, duh, of course you would have no progesterone. The doctor didn't ask you like how long your cycle typically is. If you have a 60-day cycle, you should not be testing on day 21. You would never have ovulated on day 21. In a 60-day cycle, subtract 14-ish days, you might have ovulated on day 46, right? So then add 7 days from that. If you have a 60-day cycle, let's look at progesterone on day 52, day 53, and see, are you ovulating towards the end of your cycle? So many women come in and they're like, well, I'm not ovulating. My progesterone was low. I'm like, what day did they pull it? Day 21. How long are your cycles usually? 60 days, 90 days. I'm like, okay, well, of course you didn't show you were ovulating. They tested you at the wrong point in your cycle. And this is where individualized medicine is like key. This is key. Focus on the patient in front of you. Ask the right questions, help them get the right answers to their questions. So, those are the typicals. When I have a fertility patient coming in, I have more labs that I like to ask for. Oftentimes, especially if I've heard that they've had miscarriages, or just if I'm doing a fertility panel, I'll ask for the MTHFR gene mutation to be pulled. If they have one or two mutations, if they're hetero or homozygous for a mutation, it just affects kind of what we do with their diet a little bit. It affects what type of prenatal vitamin that we put them on. I often like to ask for vitamin D levels. This is something, I don't know what it's like in the UK or other parts of the world, but it is so hard to get a doctor to pull vitamin D, especially where I live in California. They just assume we live in sunny California. I've almost never seen an adequate level come back on a lab, and that's adequate. In my, the lab ranges I see, they're trying to call 30 nanograms per milliliter adequate. And for fertility, I want to see it like 50 nanograms per milliliter. And so seeing like a 22 or an 18 or one I saw last week, which was 12, like your body needs vitamin D. It's not quite a vitamin. It's not quite a hormone. We see vitamin D receptors in the body, kind of like we see hormone receptors in the body. It plays more of a crucial role in blood sugar management, metabolism, and fertility than I think we even know yet. And sometimes getting that number in range is incredible for women with fertility. The other thing I really like to request and ask for, and would advocate any woman with PCOS ask for, is a full thyroid panel. TSH is oftentimes what the doctor will order. That's your thyroid stimulating hormone. It comes from your brain. It talks to your thyroid, which it's a butterfly shaped organ in your throat. That it's what tells your thyroid what to do. And oftentimes, like if you talk to an endocrinologist or an OB, they're trying to see it under like 4.2. If you talk to a naturopath or a functional medicine practitioner, like we really want to see it under like 2.2 or 2.0. And anything above that, you really start needing to dig deeper. So pulling a full thyroid panel, looking more at the thyroid hormones than just the thyroid stimulating hormone, T3, T4, reverse T3, looking at the thyroid antibodies, that can be really helpful. I don't advocate like everyone going on a gluten-free diet, but if you have hypothyroidism and specifically Hashimoto's hypothyroidism and you're trying to conceive, I think it can be really powerful. So getting a full thyroid panel can help somebody answer the question of if they're the type of person with PCOS, should maybe consider going gluten-free. And again, that's individualized care rather than just like a blanket recommendation to everyone with PCOS to try this one thing that worked for me. What worked for me doesn't work for every one of my patients. And what worked for Patty doesn't work for Susie. And so you really have to look at them, their lab work. Getting good lab work is incredibly helpful in this pursuit.
Yeah, definitely. I think the first thing to always do is to get the labs done, to know exactly what hormones are kind of imbalanced, and also looking at the minerals and the vitamins and minerals.
And magnesium, like you said, minerals. Magnesium's huge. Another one that I didn't mention, vitamin B12. If you've been on birth control for a very long time, or if you're on metformin,
yes,
your body is likely, it's not that you become deficient in it, it's that those medications make you use the vitamin B12 that you have. So you need more of it. And so if you're on metformin, you should be supplementing with vitamin B12. If you've been on the pill and you're coming off of it, your B12 numbers may be low. If you don't eat meat, your vitamin B12 numbers are low and you likely need to supplement. So that's another probably one that I would put on like my basic hormone panel.
I think it's AMH as a test. Is that something that you should get tested for PCOS and fertility purposes?
So anti-Malarian hormone that's a really good question. I don't specifically request it, and I see it a lot because most patients come to me sometimes after they've done fertility treatments and nothing worked. And so here they are. Honestly, in PCOS, I treat other patients locally to me. I don't take distant clients that have fertility issues not related to PCOS, but I see AMH low in patients that don't have PCOS more often than I see it in patients with PCOS. They think, and it's because probably there isn't a better parameter to be testing right now, according to what we know from research, that your AMH level will give you some indication of your ovarian reserve. So like how many follicles do you have left in your ovary? And honestly, for PCOS, because ovulation is arrested or stopped for so much of our life, egg reserve is not often the issue. It's getting those eggs out of reserve and put into the game. That's usually more of the issue. So I see why people test AMH. I don't often see it being an issue with PCOS. It might be in an individual coming in at an older age. Your AMH levels typically decline with age as your ovarian reserve declines. But no, it's not typically on my like first panel. I don't find it incredibly useful. When I look at labs that we should pull, I want to have a reason how it would affect our treatment. So getting someone ovulating, improving their blood sugar, like at the end of the day, whether we get them pregnant or not, they probably need to feel better. And so knowing their AMH level doesn't really affect what I would do in practice. Knowing their LH and FSH level, that would really affect it. Knowing that they're not ovulating at all, that would really affect it. Knowing that they have high prolactin, that would really affect it. So I think that there should always be somebody looking at the labs going like, what's the reason that we would pull this and how would it affect what we do? If you have an MTHFR gene mutation, it affects the supplements I'm going to give you. So we need to know that information.
So for our listeners, what is the MTHFR?
Gene mutation?
Yeah.
So the reason why it's important for fertility specifically is it affects how your body essentially is able to translate vitamins from one form to another. It's a way to essentially like methylate. So for instance, folic acid is something that has been kind of supplemented in our food environment for a very long time. High levels of folic acid, when you have this MTHFR gene mutation, can be dangerous because you don't have a way to turn it into kind of the usable form in your body. So a lot of times we're looking at like a methylated folate instead of a different form of folate. You can have a folate that's not methylated that's also not folic acid. So folic acid's kind of the synthetic version. Folate's what you're going to get through food. But turning that folate from your kale in your salad at lunch into the usable form in your body, if you have this MTHFR gene mutation, it's just harder for your body to do. The reason why it's worth testing is that 40% of the population has at least one of these gene mutations. So we're also seeing actually some emerging research that recurrent miscarriages may be linked to sperm from somebody that has at least one of the mutations for MTHFR. So it's not just a female thing. Like if you're experiencing multiple miscarriages, first of all, my heart goes out to you and I know how hard that is. So the fact that you're listening to this and you want to keep trying, like, you're amazing. But your partner should get checked too, because maybe he should be on a methylated version of a vitamin to help his body utilize the vitamins more effectively. Yeah. So, I mean, I could give you like what it's called, but the word's this long and I don't think it would be very useful. So just have somebody type in MTHFR. And there's tons of, I mean, Google's a rabbit hole. They can look at it. They could ask their doctor for it. Typically when you get to the point where you're working with like a reproductive endocrinologist or a fertility specialist, they're starting to look at this too. So
interesting. Awesome.
Yeah.
So one thing we kind of touched on with spotting, this is a question I always get asked, and it's like, what is spotting? Like, what causes it? Why am I experiencing spotting between periods? Like, what is it?
Yeah. So there's a number of reasons for spotting. I hear from a lot of women that they spot after sex, and this is more often in women who are spotting after sex. Is happening more often in women that are having very long cycles and I suspect, and then we confirm, have not been ovulating. And so I don't know that there's been real studies on this, but I think that part of that is just their uterine lining is so built up. And so any amount of kind of movement or orgasm or penetration could disrupt a little bit of that. But more often, there are a number of reasons for spotting. One reason is implantation bleed. I think this would be the happy reason to be spotting for anybody who's trying to conceive. So this is when an egg's been fertilized and it travels through the fallopian tube and implants into your uterus. As it kind of burrows in, it dislodges a little bit of blood, and then that comes out. That's often not what like probably your listeners or your audience is writing in about. They're likely writing in about, it's often like a fluctuation in their hormones. So they have really high level of estrogen. All of a sudden their estrogen dips really low. That would be my guess for most women. When a woman's not ovulating, they're not creating that progesterone, and there isn't that. It's kind of like, think about laying bricks and you didn't put any of that like cement glue in between it. Mm-hmm. You have this very unstable wall, and something comes through and kind of nudges it, and some of it falls down. Maybe not all of it, but some of it falls down. And that's how I like to think about spotting that comes not around ovulation or implantation. It's this kind of like reinforced environment where your uterine lining is so thick and built up for so long, and it's just unstable, and sometimes it breaks through. So I would say that's probably the most common. A lot of times women will also spot like 4 or 5 days before their period. And I see this more often in women who are ovulating. So they do have some progesterone, and then the progesterone levels start kind of coming down. And then it's like their body is not ready to get ovulate. There's still some progesterone to keep that lining intact, but there's enough of a dip that just a little bit of blood and lining comes out. It's a question I get a lot too. And maybe I need to write a blog on it or something, because I don't think that a lot of people are addressing it. The other question that I get a lot about bleeding is like, why am I bleeding for a month?
Yeah.
And we talked about this briefly at the beginning. Part of that's because they're not ovulating and they're building up such a thick wall, but also I've had a lot of clients recently who have had uterine polyps, and the polyps are the reason for the extended bleeding. And the bleeding isn't really menstrual bleeding. It's like legitimately an active bleed inside their uterus. And so if you're in a scenario where you've been bleeding like 2 or 3 months, I get DMs on the Instagram all the time about this. Like, I can't answer that question. First of all, I don't know you and I don't know your whole picture, but I can't go in with an ultrasound and look for a polyp or a fibroid or a reason for this. And you should go see somebody who can do that. I think women's intuition is not often relied upon enough. You know, it's like I did some advanced herbal training with Aviva Ram, who used to be a midwife and now is an MD. And she really promotes, and it's, since I've been working through her material, it's been more kind of a part of my practice to really listen to a client and listen to her intuition. Like if she says to me, for some reason, I just don't think I should be cooking with cinnamon, I'm like, hey, great, don't. I believe in your body's ability to be telling you something, even like subliminally. If you have some sort of intuition on this, so if you have an intuition that this bleeding or this spotting is weird and wrong, by all means, please go get it checked out. Don't just think, oh, it's probably ovulation bleeding, or it's probably, you know, my lining just got built up. If it feels wrong, if it looks wrong, if it's concerning to you, if you're getting tired because you're bleeding so much and maybe you have some sort of anemia, please go get checked out. Like, I think sometimes it appears that I'm not very happy with OBs. I really respect them and want them to do their job. And I think we just need more advocacy on how that they can do their job better with PCOS, but you shouldn't be afraid of your OB, and you should go get checked out if you think you need help.
Definitely. I think women are just a little bit afraid of going because people don't understand. But at the end of the day, if you're DMing someone, they're not going to be able to give you the right answer without physically seeing you in person and testing. So while we try our best to, you know, support people through DMs on Instagram or messages, sometimes the only way is to go to the OBGYN or someone who can physically assess the situation to give you the right answer. So yeah, I think not to be so afraid, or just go and get it checked out.
Write down your questions, you know, go in prepared, bring a partner or a friend. I mean, in COVID, you might not be able to, but like bring support if you feel like you need support. But yes, like go get checked out if you think something's up.
Yeah. So before we move on to some of the nutritional and lifestyle habits that can help support ovulation, what are some of these signs that people should be looking for?
Yeah.
You've been touching on some of them.
Yeah. So the best predictive sign that your body is about to ovulate is your cervical mucus. So really when I'm talking about like fertile cervical mucus, think about like when you blow your nose and you have clear snot, like you pull the tissue away from your nose and it's like some of it's still stuck to you and some of it's stuck to the tissue. It's kind of like, I don't know, almost elastic. Yeah. Stringy. That is what really good fertile cervical mucus looks like the white of an egg. It can be more creamy or lotiony. It can be not enough to be showing up on your toilet paper as you're wiping, but just feel lubricated as you wipe from front to back. And oftentimes women with PCOS actually make a lot of cervical mucus, and sometimes they make a lot of fertile cervical mucus. Your estrogen levels really help dictate how much and when you're making cervical mucus. And we tend to have high levels of estrogen a lot of the time with women with PCOS. And so watching for this can be like a little bit of a false alarm a lot, like, okay, I might be about to ovulate. oh, now I might be about to ovulate. But it is really the best way that you can predict ovulation with what your body's telling you. The other way that you can predict ovulation is by checking the position of your cervix. So during your period and towards the end of your cycle, right before you have your next period, your cervix is kind of lower in your vagina. And as your body prepares and tries to ovulate, it moves higher up into your vagina. And so if you, with clean hands, I like to do it in the shower. Take 2 of your fingers and insert up inside of your vagina. You're looking to feel for it feels a little bit like the tip of your nose, your cervix. And you're looking to feel for that. And a good time to start looking is right after your period, because it should be lower and easier to find. The other thing I like to tell people is, like, when you hit your uterus, I have this feeling where it's like, ooh, I just felt something. Whereas, like, if I'm on the side of my vagina wall, it's kind of like, oh, okay, where is it? Where is it? And then as soon as I hit my uterus or my cervix, it's like, oh, okay. It's not painful. Doesn't feel good. It's just like, okay, I got to it. Some women can't even reach it when they're getting close to ovulation. So you're reaching up inside of you and you're like fishing for it and you can never get to it. That's a really good sign that your body's trying to ovulate. So cervical mucus and cervical position, it'll also feel softer around the time that you're going to ovulate. When it's lower, sitting lower down, it's kind of harder, firmer, and more closed. And I got asked this question the other day on Instagram after I was talking about this a little bit. Somebody asked, well, isn't your cervix open all the time? And that's like why you should be careful to not get pregnant on any day of your cycle. And actually, your body continues to make cervical mucus after you ovulate. It's just the type of cervical mucus it makes is different. And it literally is like glue and plugs the opening of your cervix up. And that plug doesn't move until you have your period or you have a baby. Like when people say like, I lost my mucus right before they have their baby, like the mucous membrane, that is literally what started like 9-10 months earlier that they lose. It's happened after ovulation. So yes, an opening is still there, but it's plugged up with a certain type of cervical mucus. So those are the 2 predictive ways. The other ways that you can tell just from your body signals alone are basal body temperature. So having a basal body thermometer, which gives you like a second decimal, so like not 97.8, 97.82, or not 36.9, 36.93 degrees Celsius. So that thermometer, if you take your temperature as soon as you wake up every single morning and chart your temperature, you'll be able to see a thermal shift if you're ovulating. Now, a lot of women have disrupted sleep. They might be shift workers. And the idea of doing like basal body temperature every day is like feels a bit much for them. And so there are like options out there now where it's not something you have to necessarily like take your temperature every single morning. You wear something overnight. So there's a number of them. I think Corey might have even gone over some of these when she was on your podcast, but there are some wearables out there that you can do if that's more suited to your personality or your mornings. Or for me, I'm actually testing a few of them out so that I can give honest reviews on Instagram of the different ones. Yeah. And so it'll be interesting to see. I'm also taking my temperature in the morning and tracking that to see, is it as clear in these predictive kind of wearable things as it is just on my normal, like $7 from Walmart type of thermometer. But looking for a thermal shift, usually about 1/2 degree is enough. And it's obvious when it happens. If you sleep in on a Saturday and you saw your temperature higher, it's because you slept in. Your temperature goes up over time. If you wake up really early one morning because you have to be somewhere, like at the airport at 5 a.m. and you wake up at 3:30, your temperature is going to be lower than it normally is. And so some of those anomalies, you just need to learn a little bit more about basal body temperature. But the thing to know about it is it does not predict ovulation. It confirms ovulation has happened. And why that is so important is by the time ovulation's happened, it's kind of too late to get pregnant. We need to have intercourse as we're following like your cervical mucus predicting ovulation, not once you see the temperature spike, because once you really see the temperature spike and you can confirm it for 2 or 3 days, it's too late to get pregnant. So those are ways you can tell just by what your body's telling you, and really for fairly cheap. I mean, cervical position and cervical mucus just take learning to look for and getting comfortable doing. Not everybody's comfortable putting a couple fingers up their vagina, and I get that. So cervical mucus is at least easy to like, what's the sensation when I wipe and I'm dry versus what's the sensation when I wipe and I'm wet. I mean, when I have cervical mucus, I can feel it just walking around like normally. Like I can often tell before I even get to the bathroom, I just have like cervical mucus down there. So some women just can tell. And the more you do it, the more you get in tune with those things. There are other like more technologies that are coming out to track like your baseline LH and your LH surge beyond baseline. I haven't used those with a lot of clients, so I really can't speak to like if that's as good as just getting to know your body and the cervical mucus. At the very least, I really like people to be doing some sort of temperature monitoring, whether it's with a thermometer or one of the wearables, because month after month, it can help us see like what was your kind of cycle report card. Did you ovulate earlier in your cycle? Once you ovulated, did you have a long enough period of time between that and your period that you could have sustained a pregnancy? So your luteal phase, is that 10 days long or 14 days long? Those pieces of information help us change your treatment protocol and zero in on issues. And so temperature tracking is kind of paramount when a client starts working with me. They have to be willing to do it, or like it's a little bit like shooting, a dart with no board to land on it. I just don't know. I don't have a way to assess if the changes we're making are helping with your ovulation.
Yeah, I think it's important to be able to track certain things. So it's quite sad that we weren't taught it when we were growing up. But yeah, I think I'm glad we kind of touched on these signs so women can start implementing them in their 28-day cycle, assessing certain things to see if they're ovulating. So what are some of these things that we can what factors can we start implementing in our daily life, in our lifestyle, to start improving our chances and the frequency of ovulation?
Yes. This is the money right here. This is a good step. And it honestly is not a sexy answer. Like everybody wants take this supplement. You think you have insulin resistance, you have to balance your blood sugar. It again, your blood sugar. Blood sugar management is sugar key. Protein on plate, meal and snack, high amounts of fiber. So fiber could come from fruits, could come from vegetables, could come from nuts and seeds. I often say add a meal at the very least. So kind of getting your food pairings down, incredibly important. Quality sources of fat, not being afraid of carbohydrates, but eating quality carbohydrates and not letting carbohydrates be the basis of the meal. In my American culture, we eat a lot of pasta. We eat sandwiches in between two really big slices of bread. And there's often not enough protein to help with the blood sugar kind of roller coaster that you would be on if you ate a very predominantly low fiber carbohydrate meal. So it's not sexy. It takes time for it to trickle down to your ovaries, but blood sugar and the reason why it's key, high levels of blood sugar, your levels of insulin. Women, 70% of women with insulin doesn't become insulin resistant. There's a couple crucial for ovulation is your ovaries. And so your ovaries bombarded over insulin and are hey, great, too much blood sugar, too much energy. High levels of insulin in the blood increase your local levels of testosterone in your ovaries. And that local level of testosterone really impacts your ability to ovulate. So while it's not a fun answer, while it affects every time you eat, blood sugar management is like number one key. And that can look very different for different people. I personally crave beans and love beans. And so a lot of times beans are the carbohydrate rich food that I have at a meal alongside of half a plate of vegetables and some fruit and a good amount of protein. One kind of quick tip I like to give everyone is like try to make your meals, the protein source, look as big as a closed fist, and then make whatever carbohydrate source on the plate is there equal to or smaller than that amount of protein. And that's the way you don't need to track what you're eating. We don't need to count your macros. We can just see visually on the plate, like when you piled up your grilled chicken breast and you put your baked potato next to it, was it like one of those monster baked potatoes that was 3 times the chicken you served yourself? That's not going to be great for your blood sugar management. So managing blood sugar, super key. Another way to improve ovulation is to lower insulin resistance. And if we're attacking it from blood sugar, great. We can also attack it through quality exercise. And so improving blood sugar and insulin resistance through exercise doesn't need to look like training for a half marathon, doesn't need to look like killing yourself for 2 hours at the gym every day. Some level of body weight or weight resistance, really helpful. Yoga has been shown to improve insulin resistance. Really any movement. I mean, I've seen studies where just 3 weeks of consistent 150 minutes of exercise has improved insulin resistance. So moving more than nothing is better, and moving smarter than just, killing yourself on cardio all the time is helpful too. What I do is like in between clients at my office, I just stand up and do 10 squats. It's like, it took me 15 seconds. There's a way that I could sneak in something that's going to eat up a lot of the sugar in my blood really quick. I used the biggest muscles in my body and I didn't break a sweat. And then, so I do that 10 times a day. I did 50 squats. That's awesome. So even finding ways to kind of sneak in movement can really help with insulin resistance. Then supplements are helpful. I really don't like to be like a supplement pusher. And I think that they should really be tailored to an individual's lab work and symptoms and goals. So if your lab work says you're really insulin resistant and your goal is weight loss and not fertility, I might treat your insulin resistance with a different supplement than I would if your goal was fertility, right? So sometimes it's not just lab work and symptoms. It's like, well, what are we trying to do 6 months from now? What are we trying to do 2 years from now? We might use something like berberine right now and then an inositol product later. So supplements can be really helpful in terms of ovulation. So some of the big hitters, in my opinion, based on the research and what I've seen in practice, are inositols. We could go into a lot about inositols, but the kind of the long and the short of it is that it increases your ovaries' responsiveness to LH and FSH. And so it kind of trickles down to an improvement in how quickly you ovulate. They also help with other factors like insulin resistance and cholesterol levels. Inositol is a great supplement for PCOS and very well tolerated kind of across the board. N-acetylcysteine, I've seen a lot of improvement in clients, has both blood sugar and insulin benefits and ovulatory benefits. Usually people take inositols close to 4 grams per day in divided doses. And acetylcysteine, I like to see it like 1.2 to 1.8 grams per day in divided doses. Then moving on, vitamin D is something I always optimize in a fertility patient. It's also really important in terms of immune health and kind of in the current COVID environment. Vitamin D is something anybody comes in, I want to see and optimize for them. ubiquinol. So that's a specific form of CoQ10, is shown in a lot of research in terms of egg quality and sperm quality. So I'll often get both partners on ubiquinol, like a ubiquinol QH. And dosing there really depends on what's going on, how long they've been trying, how old they are they doing IVF, IUI, are they trying to get pregnant naturally? Berbering's another one that I'll use in fertility patients, and especially if they're not on metformin and inositol alone's not really doing the job, I'll layer in something else to kind of help with the insulin resistance picture. So berberine I use sometimes. Magnesium, zinc, licorice, peony. I mean, I could go on and on and on. There's good research for a lot of these. It's just the indications when to use them really varies per client. And I would highly recommend working with somebody, not necessarily me, but somebody that understands the power of supplements and can help dose them for you and for, again, your goals, for your lab work, so that you're not A, throwing away money, or B, doing something that might be working against your progress. For instance, I don't give everyone Vitex. A lot of the naturopaths that I work with give every PCOS patient Vitex. I think that there are times where it's better indicated than others. Oftentimes we don't really need it. And so if we don't need it, why throw one more thing in the mix? So, working with somebody that can really tailor it to your needs, I think can be the difference between conception taking a year or 3 years, or conception taking 6 or 9 months.
Vitex was actually something I wrote down. I was like, because that's a supplement everyone's always asking, oh, I've seen this, should I take Vitex? And it's just like, sometimes with regards to PCOS, it could make matters worse. You have to always tailor the supplements. Like you would create a nutritional program, your exercise, supplements require a tailored approach. You can't just, go to the store and buy every single supplement said to be great for PCOS, because
right.
We have to honor our hormonal imbalance and, assess it based on what our goal is. Like you said, is it fertility? Is it just weight loss? Is it to help your acne? Like what kind of, and addressing that root cause, like what are we trying to fix here? Like what's the issue? And then taking everything and making it into like a big plan.
Yeah. I mean, like yesterday I got a DM from somebody like, I've read that curcumin, so that's an active ingredient in turmeric. Curcumin's really good for PCOS and inflammation, and should I be taking it? I'm like, well, first of all, girl, I don't know your whole picture. I don't know. But curcumin, like, it's not at the top of my list of things. Have I recommended it? Yes. Have I recommended it to like 90% of my clients? No. I would give it in a very tailored response. And, a lot of times these herbs that we cook with or can use in teas, I prefer to use in that way, and more of a food as medicine. Cinnamon's really powerful in blood sugar management. So make a tea and add some extra cinnamon in it, or as you're cooking, use extra cinnamon. If you're interested in the anti-inflammatory effects of turmeric, cook with it. Like there are tons of recipes you can add turmeric to. I even add it to my spaghetti sauce, and it's way more used in other, cultural, cultures and dishes. Nobody would ever think to put it in spaghetti sauce, but like it works, doesn't overpower it. And we just got one more way to get that nice herb in. So a lot of times with herbs and spices, use it in a tea, use it in cooking, unless somebody can really tailor it to you. And the other thing about supplements is women are trying to get pregnant oftentimes. Not all these supplements, the supplements that are safe to help you get pregnant may not necessarily be safe while you are pregnant. And so working with somebody who's been in the research and knows can help you kind of tailor that. So for instance, I would never keep somebody on Vitex after they conceived, but I would keep them on inositol, because inositol may help them have lower risk of gestational diabetes. So knowing the differences can be really powerful in helping somebody avoid, unnecessary side effects or just things. It's not ethical to test a lot of these things in pregnancy. So we sometimes just don't know. And if we don't know, we're better off erring on the side, I think, of caution than being a little risky.
100%. I think it's really important to be working with someone who knows about supplements and the effects on the body before we just take everything, because it could be doing a lot worse. And herbs and stuff like this are super powerful. We often think that, you know, we don't think they are, but they actually are super powerful, so we have to be careful. But yeah, I think we've touched on a lot of
so much.
Yeah. I think our listeners will have enjoyed this episode and learned a lot from you and the information. But before we wrap up, how can our listeners connect with you? Where can they find you?
Yes, thank you. So primarily I'm on Instagram, so at Pcos Fertility Nutrition. I run a how to get pregnant with PCOS type course. It's called Find Fertility with the PCOS Plus method. And that's open for enrollment at various points in the year. At least at this point, it's not open around the calendar. And so if they go to the link in my profile, if they're interested in that, they can get on my mailing list and be the first to hear about that. I have a website, PCOSfertilitynutrition.com. In 2 weeks, it'll be back up and running, but right now it's under construction. So, you know, listeners a month from now will be able to find it. But yeah, I mean, in summary, I just want everyone listening, especially that have the fertility goal of being moms and getting pregnant, it's very possible. And there's a lot of reason to have hope. So if you feel desperate or that you haven't been given enough resources or education, I want you to know that a message of hope, that I've seen so many women conceive with PCOS, carry very healthy pregnancies and have beautiful, healthy babies. And PCOS is not an infertility diagnosis. It's something that you need to manage. And a lot of the things that you can do to help you manage your PCOS are the same things that you can do to help you get pregnant with PCOS. So whether you're going to get pregnant, you know, you want to grow a family 4 years from now, or 4 months ago and you feel behind in your journey, there's so much reason to kind of get in control of this and really take care of your body. So please have hope and find help from somebody that has the resources to really help you and help you not feel so lonely in this process.
Yes, I love that advice and tip. And I'll have everything linked in the show notes, Instagram profile, the website, everything will be linked in the show notes. Highly recommend following. Post so much great information that is really just so educational, and you can really take that and implement it in your life. And but yeah, thank you so much for taking the time to join me today on the podcast. I really appreciate it. Like I said, I think our listeners will have thoroughly enjoyed it and have learned something. So thank you so much.